Good afternoon, everybody, and welcome to today's latest iteration on our 10-year plan webinar series from Digital Health. Glad to say we've got a stellar lineup once again. I believe this is our fourth or our fifth webinar. Should remember it's only 4 or 5, but I think it is the fourth. So we've got quite a good mix from across the networks, representing all the different disciplines on the MDT side of digital health, and also Alec Price-Forbes, who's joined us as well, who's going to give a view from NHS England and also his wider kind of industry experience. What we're going to do today is we are missing one of our panelists at the moment, Amit, who's a cardiologist, so he may be in the middle of surgery, so I'll forgive him if he's trying to get his scrubs off before he joins us. But if Amit joins us later, then he'll be able to give a bit of insight. We'll just do a very quick intro of everybody, followed by a short presentation from Alec, just to help set the scene on some of the AI side that's coming out of the 10-year plan, which we'll be discussing. But an opportunity for all the different panel members and for the audience to get involved with questions towards the end. The Q&A function doesn't work on this one, so if you write any questions that you've got in chat, and then we can go through those and read some of those out towards the end, some of the more popular ones. But hopefully we'll be able to go through some of the ambitions, what people are using, some concerns, some issues, and there's various issues around things like kind of bias, patient safety, clinical safety, etc., and exactly where AI ought to be used and how people do that, but also some question marks around business case and how it fits in with the wider kind of tech stack that you've got. So there will be some insight. We will follow up with a further deep dive AI webinar next year, but this is your first entrance. So I will be quiet. I didn't introduce myself, but I always assume most people know me, but just in case you don't, I'm Carl Grundy. I'm the MD of Digital Health. I'm going to start by introducing Yvette, and then we'll just go around robin from there. Over to you, Yvette.
Thank you so much. Hi, I'm Yvette. I am the lead EPMA pharmacist here at West London NHS Trust, and I'm also leading on AI implementation here. So I've got experience on the ground with that. Thank you.
So Lee, if I can come to you.
Yeah, I'm Lee Rickles. I'm the CIO from the Teaching NHS Foundation Trust, and I'm also the director of Interweave.
Thanks, Lee. Jackie.
Hi everyone, I'm Jackie Cooper. I'm the CNIO for Health Innovation Manchester, NHS GM, and the Deputy Vice Chair for the ICS Council.
Thanks, Alec.
Good afternoon, everyone. I'm Alec Price-Forbes, National CCIO, and still one day a week a practicing rheumatologist. Lovely to be here, Carl.
Thank you, Alec. So as I mentioned, Amit is missing us, who's from our CCIO panel, so that gives us our kind of rounded view. Hopefully he will join us shortly, but Alec is going to just put up a quick kind of PowerPoint and promises not to be death by PW, but we'll go and I'll pass it back over to you, Alec.
No pressure then. So thank you. Right, I'll be really quick then, so we can get into the conversation. The background context, I'll leave this slide up for people to just look at as I talk for a moment. But across healthcare systems globally, and obviously within England and the UK, we're all facing similar pressures around and growing comorbidities and people living longer with disease, but healthy life expectancy starting to stall, constrained resources, the aging population, and obviously rising expectations. The really startling fact here is 60% of people dissatisfied with the NHS last year, even though there's still huge amounts of love and trust for the institution we all love and contribute to. So really reform isn't a luxury commodity. It's going to be about survival, and we've got to radically reimagine. And I think we all recognize that AI offers practical tools that are already here and can address things in a way that just really weren't feasible a few years back. Just to provide context, so we had obviously the Darzi review last year, we had the government plan for change last December, wanting to sort of move towards an NHS that's a growth, not a health service. We had a blueprint for modern digital government in January, and then obviously the government mandate around the 3 shifts. We had the AI opportunities plan, so January was very heavy, but laying the foundations, the infrastructure, changing lives by embracing AI and adoption of responsible AI at scale scale across government, across society, and securing the future of homegrown AI. And then, of course, we had the AI being one of the 3 shifts. So those shifts, I don't need to remind colleagues on this call, they're well known. And I think it's fair to say that AI now is described not just as one of the big bets, but as a promise. It's really a commitment now of this government, and we're supporting that mission to make AI available to help support. Very quickly, we need to enable people to be supported by technology, reimagining processes in various places to enable those 3 shifts. And we need to think about it now that we move into a new operating model where digital data technology just is at the center of everything we think about, to be able to innovate, transform, operate, and improve, so that we start to be more business-led rather than being technology-led. And I'm really keen that we start to embed that into modern services framework, which is a piece of work I'll want to involve colleagues in as we go forward. And I don't know where that slide's come from. I'm just going to move forward very quickly. Just really, there is a challenge around even what we call AI. Everyone's talking about AI, but a lot of what is AI isn't, and it's really important that we have that clarification. And the government playbook definition of AI is in the top left box there, but I think really it's anything that is creating machine learning that emulates what human intelligence would do, that is able to replace those tasks. But what I would say is that technology itself doesn't heal, people do. And the greatest endeavor we have and the greatest innovation we have right now in healthcare is not just artificial intelligence, it's human intelligence. And we need to be courageous in the way we adopt new ways, but in a compassionate, empathic way, to be able to deliver benefit to those that we serve. So I'm going to skip through. We know there are opportunities already that are flourishing, both for direct care purposes as well as supporting non-clinical and back office function, corporate services, public health and prevention, life sciences. We saw an explosion during the pandemic with real recognition of the ability to take drug discovery and development into the mainstream. And we're moving into a world of genomics and personalized medicine, which is really, really important, and AI-enabled transformation. So I think where we see the shifts, ambient voice technologies, I'm sure we'll talk about, but they obviously involve creating large language models and generative AI, summarizing the consultation that takes place. But actually, we need to go further than that. And my view is that we'll be embedding that in the future in the NHS app, so that patients will be able to navigate health and care, just putting their information in with voice, not just tapping in. We're looking at a national proposition to support NHS organisations right now, and there'll be more of that to come. We need to obviously continue to invest in core infrastructure. AI depends on high quality data, and therefore we not just need to make sure that we embed and give the tools for staff to be able to use, but equip them with the skills to be able to use it. We know that 11% of staff only tell us they have the capability at the moment, and 70% are thwarted from interoperability challenges. So we need high quality data for AI to operate, and there's a mission really that AI, all hospitals will be AI enabled, and that really AI becomes a health professional's trusted assistant in the lifetime of the 10-year plan, so it seamlessly integrates across all pathways. And the final thought really is that introduction of the single patient record is going to be a key component of that enterprise architecture, but I think AI will be leveraged on that, and we need to really look at that data flow and how high quality data will be interoperable and become the lifeblood really for AI algorithms to be able to operate if we're going to get the benefit. And that will be from raw material, from genomics discovery through to the context of wearables, and how we start to bake that into a modern services framework. And we're planning to do that with cardiovascular disease and stroke to start with. That's the first sort of line that's coming in. I've talked about triaging and navigation. I think people being able to contribute into the NHS app to start that journey is more critical than just summarising 10 consultations that take place about the same problem as patients try and traverse the health and care system. We need to get it right, do it once right, in the right place at the right time. So real opportunities, and obviously this will support neighbourhood health services. I'm going to pause there. This, I mean, clearly is a huge opportunity for us, but at the end of the day, this is all about people. So we need to be mindful of 7% of the population who don't have internet, 10 million adults who don't have foundational digital health, digital literacy skills, and 30% of those most impoverished from socioeconomically challenged backgrounds who struggle to navigate health and care. And we've got to look at our workforce as well. So this has got to be a journey where we bring public, patients and our workforce on that journey of discovery, where we can put in safe, assured, reliable, trustworthy AI to leverage the capability that it can do to reimagine how we deliver healthcare. I'll pause there.
Thank you, Alec. So there is an awful lot of different types of AI, as Alex just alluded to, and there's been various discussions. At our summer schools event, I think Ewan McComsky informed me that AI was mentioned something like 647 times, but on the converse of that, physio was only mentioned once. So it clearly had a bug to bear there on that one. But there is a key point here in terms of AI is generally a kind of wide term that people use. Then people start to break it down into functions. So whether that is admin support through something like Copilot or Gemini, voice ambient AI technologies, machine learning is the traditional kind of forerunner to AI and how that could potentially work with your tech stack. But as Alec just alluded to there, a lot of this comes down to people. And I think a lot of people will be asking those questions about what it is that I can get involved in, what can I use? We spent a long time in digital health doing surveys in the past. And one of the top issues that came up was clinical engagement. So I'd just like to start with that. How do we get clinical engagement with AI in order for us to then look at what services we can provide for patients and for that wider kind of enterprise across health? I'm going to start with you, Jackie, on that one, just to give you the hardest one first.
No pressure. Thanks very much. So I think clinical engagement is key, isn't it? The key to good digital transformation is that it's clinically led, it's operationally delivered, and it's digitally enabled. And I think we've all been guilty of putting the tech first, and that's why we failed, because that just doesn't work. So engaging our people and making our people lead the innovation and the digital transformation is the key to it. I think in terms of AI, we run a real risk of not doing that and not doing that effectively. I think we run a real risk even for the simplest of things that we're using, like the Office 365 Copilot, which we use nowhere near the full functionality and capability of that. I think we run a real risk of switching it on and walking away. And if that's the plan that we've got, we're never going to get the best benefits out of it. For the nursing, midwifery and allied health professional workforce, which is always my remit, holding hands with them at the elbow support, showing them, teaching them, and making sure that they're getting the best benefit out of the functionality that they've got is the key, because you walk away then and then you reap the benefits. But if you're going to switch something on in your organization and say off you go, you know, that's it. And I remember deeply in COVID with Teams, actually, and anybody who knows me, I'm a CNIO, been a CNIO for a long time. I am not Lee, I'm not a technical genius, and I don't think Nora should be. I can hold my own now, I've been in it that long, but I'm not a tech expert. But actually getting nurses, midwives and allied health professionals to use Teams in COVID was really hard because they switched it on and they walked away. So I was the one in the room going, this is what you do, this is how you can do it. So even basic functionality, making sure that it's deeply embedded in their practice and they know how to get the benefit is the key to all of this.
Jackie, Lee, can I just come to you on the same format as well? Because obviously when you implement any new software or new service, you've got a whole workforce that you've got to worry about how you get the best use of that.
Yeah. So, I mean, it's whether it's AI or any of the other technologies, there's probably 2 or 3 different aspects. And Jack is absolutely right. You've got to understand the why you're doing it. And again, with AI, we've got to focus on how that's going to be better quality, how it might be more repeatable. You know, AI tools don't have bad days after hangovers. They can work 24/7, but to the same degree, we've got to be as confident in its ability as you would as a person. So, you know, we get professional revalidation assessments where we've got to have that same confidence with the AI tools as a medical device, which is part of the excellent work that NHS England are currently doing to help us have a very clear understanding. So from a workforce point of view, you've got to take it as an organisational transformation. And AI is definitely one of them, because I think the challenge around AI or any software as a medical device is it's not seen as a medical device. It's not seen as the same way as a machine that goes bleep. It's not seen the same as a heart monitor or something like that. You know, nobody would trust me if I went into my garage and built a heart monitor, which, to be honest, I probably could do with my engineering background. I wouldn't class it as a medical device. It would work, but the same aspects sits with software as a medical device and AI. That I can also sit down and use ChatGPT, train it up on a load of the internet stuff, and then we'll have all sorts of dodgy things, and that's quite important. So I think from an organisational point of view, there's one thing around the ethics and the governance, which is absolutely essential. Do you have the right guidelines? Do you have the right understanding, especially around AI, to make sure you can get the best out of it, but also you're safe, and you're safe for patient care as well? Because the last thing we want to do is have adverse effects that was unwarranted because we didn't do the right thing. The other one is know that we've actually got problems to solve. So where are we focusing? Is the real issue trying to remove bureaucracy from clinicians so they've got more time to care? And there's lots of them examples. Or are we really looking at new ways of accessing? So using chatbots, for instance, for talking therapists for access, because you just need to reduce waiting lists, you got access issues, etc. That type of thing. The final thing is probably challenging the organisation itself into not recreating what we already have. So we have a risk of, when we go digital, that we recreate paper but in a digital format. So all of a sudden, we've just recreated exactly the same process. And the same could be the case in AI, unless they really, seriously understand, one, the technology, but also where we really add value around patient care. Otherwise, we just recreate the same bureaucracy and challenges and processes. And that happens in every effectively evolution of technology. So, I mean, these days I don't see many farriers or horses or anything like that. But if you went back 100 years ago, there was lots of them. I mean, basically the German army run World War II on horses, for instance. It wasn't mechanized in any shape or form. So if you ask them people what did they really want, they want faster horses. We really need to be looking at jet planes, and that's where we need to challenge ourselves on current practice, current operation, which does get quite challenging to have a conversation of how do we change practice and operation but still keep it safe. And it's a bit scary because it's different. So I think when you've got all them things together, it can be spectacular and work really well. When you've got one of them items missing, it can be an absolute disaster. And I think that's the key bit of making sure we're doing all the right things. And you've got the organisation behind you, we've got the right governance, and we've got the right aspirations, because we've got to improve, and that's the key bit. It's no good putting AI in and we've still got the same performance. And at that point, Carl, I'm surprised you didn't cut me off at the knees by now, mate.
Don't worry, you said you had 3 points. I needed to let you finish all 3, Lee. Thank you.
Okay, I just won't get asked again.
If I can come to you for your views, and then Alec, I'll come back to you.
Yeah, I agree with everybody else so far in the sense that investing in digital literacy and time is really important. So to Paul's workforce principle, I feel like that really remains true, that 90% of the NHS roles that exist right now require digital competence. So engagement really collapses if the training is rushed or unpaid. And so I think that's something that we definitely need to prioritize, protecting clinical time for learning, co-designing with the people using the products as well, and testing to make sure that the digital skills part of the is also part of the revalidation and appraisal frameworks. That would be really good as well. And then having the feedback visible. So when people do give us feedback and through the co-production process, they can see that their feedback has come back and is actually being demonstrated through the software updates and things like that, I think is really important, because I think the tangible feedback cycle sustains motivation and signals respect to the people that are using the process, using the programs as well. So yeah.
Thank you, Yvette. Alec?
Yeah, no, I mean, similarly, I think I just want to pick up on probably 3 points. The first is that AI is different, and we need to be recognizing that we need to modify governance accordingly. So we've just finished a task and finish group to come up with an AI governance policy, and it's been quite challenged actually, for obvious reasons. The autonomous nature of AI systems make it really difficult to assign accountability to individuals if harm occurs. The complexity of AI systems prevent either users or affected individuals from explaining or understanding the link between system outputs and decisions. And so provides further challenges around assigning accountability, and the scalability of AI makes it particularly difficult to define legitimate values and governance frameworks. And there's things like simple things like technology readiness. I mean, we don't understand with the fast pace of change, if I just use one example, ambient voice technologies, to what extent performance or data or model drift are going to impact as we go forward. So there are a lot of new considerations that we need to be thinking about as we move through into this new era. I think we looked at the government playbook. There's quite a good, which I'll put in the link, of some 10 overarching principles from what AI is, and we define it, and we agree a definition, and we know what the limitations are, that we use it lawfully, ethically, and responsibly, through to understanding what AI, what you're using for what purpose, and that you've got the skills and expertise needed to be able to implement and use AI solutions. So that brings me to the second point around implementation that you mentioned, Carl, and I completely agree, Jackie, with what you said. But we're defining now, we're creating an implementation model that we want to blueprint, and that implementation model is synonymous with benefits realization. So everything we do should be safe, assured, and deliver proven benefit. But if we're going to deliver benefit in terms of improved outcomes to those that we treat and serve, then we need to invest in all of the bits from go live through to realize benefits. And the reality is, we've not done that. And we've done it really, really badly. So we've got to be honest with ourselves and accept that we've spent lots of money on tech, but we've not invested in reimagining how that technology, digital data platforms can reimagine services. And we've not done the change management to realize the benefits that are writ large in all those business cases. So that brings me to the third point, that we are really keen, as I mentioned, to bake in as the golden thread in the new modern services framework as the operating model for the 10-year plan, if you will, that we just make digital data and technology and AI as leverage, because we can start to describe where it fits, both for the member of the public, for the patient, and for the healthcare professional. And then we need to make sure that we equip those individuals with the right digital skills, as been alluded to be able to avail themselves. And that way we'll be talking about an operational model where we are really truly trying to benefit and moving from a transactional productivity, dare I say it, approach that we have at the moment, understandably, towards an outcomes and values based approach to healthcare, where we're not talking about the tech or the AI, we're talking about how are humans interacting to actually deliver the benefits to society and to the individual we're treating.
Thank you, everybody. Amit has been able to join us, so Amit's going to hopefully flash up shortly, and he can give a quick intro. One of the things I will ask Amit to then talk about is standards, but I just wanted to pick up on a couple of points there. We see this quite a lot with implementation, that sometimes governance can be there as a supporting vessel. Sometimes it can be there as a brick wall that actually stops some transformation. Some of this reflects into standards, which Amit's going to come on to, but also, as Alec alluded to then, with the implementation and the benefits realization. Benefits realization only happens if you actually are measuring where you are now. And I think it's much easier to start to measure benefits when you understand where you are now and then the measurement all. It also links to a question around what evidence is there to decide what you should implement from the AI in order for you to decide what you then should measure. So I'm going to hit on the governance and standards with Amit, and then we'll move on to that next, if that's okay with everyone. Amit, do you want to intro yourself?
Oh, thanks, Carl, and I'm sorry to be late. I'm on call on the front line, etc., and been in A&E looking after cardiac patients. I'm a cardiologist by day job. I'm also a Chief Research Informatics Officer and a Clinical Safety Officer, and I'm also co-chair for UK Research and Development Leaders Group for the Clinical Working Group, and also an executive for UK Digital Health and Care, which is another group that's trying to fill the space from the FCI, so representing some hats, etc. But what I'd love to build on in the standards and so forth is that we do have 40 or 50 years of evidence basing how we deploy new devices or drugs, so pacemakers, stents, etc., drugs, masses of anticoagulants, statins, ACE inhibitors, you name it. And what we normally have is a phase 1, phase 2, phase 3 approach, and then the randomized randomized control trial, the landmark randomized control trial, tells us, okay, what is the control group, where we are now, Carl, and then what did we achieve and what did we have to invest as a cost to do that, and what harm did we do versus the benefits, and so we can appropriately balance risk-benefit ratios and look at health economics, cost effectiveness, clinical effectiveness, and suitability for patients, and then generalizability into any setting. Is it primary care, secondary care, is it mental health, is it social care, etc., of that technology. Pacemakers have been around for 60 years and they're the best intelligent automation tool. And so for me, the clinical application of AI should start with intelligent automation without causing alert fatigue, having appropriate contextualization. I've just seen a young man who's got 2 troponins, 600, 620, after he's had tonsils and antibiotics for tonsillitis 2 days ago. Now, is this an acute coronary syndrome? Is this myocarditis? Is this a PE? You know, some AI rules of education of cutting down stochastic probability might be really useful for the juniors on the floor, etc., the residents, to say, what do I need to do next? So in that sense, it might be really useful. However, what I don't want it to do is throw us in a direction when it's untested or unvalidated. And then lastly, if you do randomized controlled trials of before and after, so multiple hospitals, let's say those with and without that intelligent automation switched on, and in fact, you would cross them over, we could switch it off. That offboarding mode, are we ever going to be able to step back if we have to withdraw an IA or an intelligent or an AI tool? Are we ready to actually step back as human beings to get back into, okay, we're no longer maintaining that system for knowing where the ambulances are, and we've got a plan B that we can cope? And if a new AI comes along, how do you compare that AI for skin analytics, for example, let's say for cancer? How do you compare one AI against another for X-rays or CT scans of the brain for stroke, etc.? What are the standards by which we say that is a sufficient jump up that we need to move towards that system? And then what do we do with that legacy data from that previous AI, and is it portable? So there's so many things to think about there. So I hope that's okay to open a can of worms. But we do have a pathway. We do have NICE. We do have it saying mandating these drugs. Phase 3 has been really useful. There are ways that we can draw on from the pharma and device world. And I wonder if Alec and others at the executive level will be thinking like that to say that's how we do robust clinical trial evidencing. Thank you.
It makes super helpful. Yvette, could I come to you next? Then Alec, I'll come to you because there's a couple of very central questions there I want to ask you.
Yeah, I think my worry has been that AI adoption is outpacing regulation just because the DCB 0129 and DCB 0160 haven't substantially been updated since, I think, 2018, though updates have begun recently. So we want to be the most AI-enabled care system in the world, and we definitely have the capability to do so. We just need to request specific things because existing standards were designed for deterministic software, not learning systems that can change their behavior over time or optimize for the wrong things, like optimize for speed rather than accuracy. So I think with real-world deployment, what we should be requesting are logs of things like red team testing, so things where you're actively antagonizing the AI, ensuring that it will react safely. So asking for things like that are like standards that don't exist or things like that, essentially just to make sure that it's behaving safely even when antagonized. And then there's also a risk of steganography, which is communication between AIs that we aren't able to trace ourselves and we're not able to, decode. And so making sure that they are within, like, they're only acting like in the ways that we expect them to act and not communicating with one another unless completely authorized. I think that would be something that I'd like to see within the new updates as well. And that's, yeah, so I think that's on my end of things. Just updates to the safety standards would be something really good to see.
Thanks a bit. Alec, I'm going to come to you, but I just want to add a little bit to what we've spoken about on standards and governance. And that is the obvious question around procurement. It was mentioned by Dermot and Ming at our summer schools recently that you will be looking at a new procurement framework. And with a lot of software procurement in the NHS being 8 to 10 years, and we know software rapidly changes, you might not want to procure an AI system for an 8 to 10 year period. But the standards that we're talking about in terms of testing this and evaluating it also need, one would assume, lead to standards in terms of what that procurement looks like and best practice around procurement. So I just wanted to add that together for you.
Yeah, no, thank you, Carl. I mean, I think this is a moving feast. I can give you some sort of updates on, and I mentioned this on the CXIO call earlier this week. more broadly, that's specifically for AVT, just looking at that whole procurement piece. So we've got a bit of a challenge at the moment that there's been a lot of suppliers approaching clinicians and giving trials for free, both within primary and secondary care, etc. And we need to be robust in ensuring that what we are doing is safe, assured, and is going to deliver benefit. So we've been working at pace, both across NHS England, but with the system as well. So lots of regional colleagues have contributed to this work, and also working with NICE and MHRA. And this will be a focus in the first few months of the AI Commission, which is now starting. And that is looking at ambient voice technologies as an exemplar for AI. And what we've done is create a sort of a modern, a model sort of blueprint, if you will. It's a framework. We're not calling it a commercial framework, but more strategic framework, which outlines the self-registry compliance requirements, both from a business capability perspective, as well as a compliance, adherence, platform stability, etc. Understanding whether a supplier has the ability or a roadmap to integrate into the electronic record systems, etc., etc., and what other functionality they've got, because this is a moving feast. But if we're going to deliver benefit, we've got to be really clear. Otherwise, we won't be comparing apples and apples. So we're doing that. That's going to launch imminently. There'll be comms coming out. But we're also working at pace with NIHR, the This Institute, and other academic institutions, because it's very clear that we need to evaluate. And we need to evaluate as we go along. And then thirdly, we need a robust monitoring system. So we are going to be asking suppliers to provide real-time analytics that can be monitored and evaluated, so that we can start to understand model data drift, hallucinations, etc., etc. So this is a moving feast, but we're trying to with mid-air trying to say this has got to be a different approach, as you alluded to. And absolutely, procurements can't now be 8 or 10 years. They are going to be 1 + 1 + 1, because this is moving at pace, and we need to learn as we go along, and we need to make sure that, in addition to that sort of standard implementation methodology, which I talked about, which is that we're investing in the change management to enable our workforce and public to have the skills, that we evaluate what we're doing as well, and we can iterate. So this is going to be, work in progress, and this is the starting point. But I see it as a collaborative that we've got to build together as we move forward into this new world, because there's so many, as Donald Rumsfeld famously said, there are a lot of unknown unknowns out there, and we've got to manage the ministerial, our government's mission is absolutely clearly steadfastly on being an AI-enabled healthcare system as well as society. And we all understand that, and there are obviously huge benefits. We know the Health Foundation did a really nice survey last year of over 1,200 staff, and 3/4 were ready to support the use of AI for direct care purposes. And a greater proportion would want to use it for administrative purposes. But we've got to make sure that they use the right AI tools within the right setting for the right purpose. What's the problem we're trying to solve? And that this isn't a panacea. This is all about people. And absolutely, we've got to improve data quality, improve quality of care, and improve bandwidth for our beleaguered staff, but make sure we do it in a responsible, safe, and replicable way. And that's why I'm really keen. The Modern Services Framework for me is going to be that replicable standard way from an operating model perspective, so that we can start to bake that in. But there's lots, Carl, that we need to do, and we need to do it together.
Okay, Lee, I would like to come to you and again just slightly building on it in terms of business case, because obviously standards, procurement, all part of this kind of process. In the old days, when we used to have discussions about a paperless NHS, you would have had business cases for a paperless NHS, you would have had money from the centre for paperless NHS. Then you and I might have a frank conversation saying, I'm not going to take paper from that department because the amount of money it would cost to eradicate the paper, there's zero benefit whatsoever, so I'll leave the paper there. How would you go about tackling this in terms of a business case for getting some of this into your organisation?
So I wouldn't start with the cash. I'd start with the quality and the outcomes. There's a massive evidence base that improving quality by default reduces incidents, reduces costs. So you're starting with a patient. You start with a quality aspect. and then you work based on what you aim to achieve. Because again, replacing one bit of tech with another bit of tech, or we're taking one person out and we're putting some tech in, these are not compelling cases. This is salami slicing in the bad old days of Monitor and Foundation Trust days, for those of us that have been around long enough. Then you've got to work the numbers out. The numbers still need to balance. It still needs to work out. The NHS does not have a bottomless pit of funding. But then you will iterate. The other challenge we've always got with some of these systems is we think too long. How can we think of an AI business case for 10 years' time when AI is changing at such a rapid rate? You've really got to be looking at things that will be 6 months, 1 year, 2 years, and in year 2 you'll be changing. Things will be developing, and you're going to have a, taking a different approach, which is more of an MVP, prototyping and iteration, more what our commercial colleagues do rather than the good old NHS waterfall process. And work with the board members, work with the organisation in its own right. So there's some comments in there about IT, digital, clinic. If working separately, if that's what's happening, it'll fail anyway. It'll be a good old-fashioned IT. They put a lot of benefits. None of them have been achieved. Nobody believes it. I'm sure we've never seen any of them business cases. Rather than actually the organisation takes total ownership, tracks the need, see where the lead KPIs are for success, and how the benefits then being delivered as an organisation. So that would be my approach, Carl. You've always got to consider the money, but I'd never start with the money. Start with the problem. Start with how you can improve care and quality. Because if it doesn't do them bits, yeah, we're back to Monitor days. And I don't really want to go back there, although it might feel that way at the moment, to be honest, with a nice oversight framework.
Thank you, that's super helpful. So Jackie, again, just extending the kind of question a little bit. One of this thing about people working together is we've seen there's been a piece of activity around helping nurses with AI, but then there hasn't been the same help for physiotherapists using AI, although I know they're looking at that at the moment. And the same for where accountability potentially rests on there. Where's the fear factor? How's that supported by governance and standards? So I just wanted to come to you on that extension, Jackie, as well.
Okay, great. So I think governance there's the sweet spot of governance, isn't there? Too much is terrible, too little is terrible. So trying to get the sweet spot of governance is the place you should be. I think it is well documented that nurses, midwives and allied health professionals, huge documenters in systems, huge documentation burden. And I would say that's the case for frontline digitisation once they've digitised, because even if you start with a build that you think is sufficient, you'll end up in 2, 3, 4, 5 years replicating the paper processes that you had, because the mantra is that's what we need to do to make us safe. Let's put another checklist in. Let's check that we've done the checklist and all of that kind of process, which is really unhelpful. So in my years as a CNIO with EPR implementation, I've always been tasked with reducing time to care, and actually I'm not sure I've ever quite got there. I'll be frank and honest, I'm not sure. Probably have, I needed a bit more time, a bit more resource, a bit better work with our supplier to get what I needed in a system. What I would say AI can do from a documentation burden perspective is absolutely do that. We are consumed with documentation, and very often from a nursing perspective, and when I say nursing I mean midwives and AHPs as well, we are, as we climb the ranks, tasked with more administration work. And actually it might not be our number one skill, because we're clinicians, we've been worked at, we've progressed, we've developed, and we're now in senior roles. So that admin burden becomes bigger. And I think the more reports we write, the more we are responsible for sickness and attendance management and appraisals. That is all consuming, and that takes us away from what we should be doing, which is frontline visibility, quality and management and leadership, and we're taken away from that. AI can 100% reduce that. If we teach our people right and we get them to use the tools correctly, that can absolutely resolve some of that. And the delight that there would be for clinical end users is significant. I go back to my first point that we have to teach them how, and I think the other outcome out of it would be the data. You know, if you've got rubbish data in, you get rubbish data out. But actually, if you start using AI and the 80-20 rule, you've got professional accountability. This is enabler. This doesn't replace me as a clinician. I have to check over what I've got and what I've done, and if I'm happy with it. I think the more you check over it and the more you go, actually, that's not quite right. I think the more the your mind shift change will be, actually, I need to be better at the front end, because if I take the time, effort and energy to get better data input, I absolutely then will get better data out, and this will be even easier for me. I think just a point about clinical safety, because it's a big issue for me and has been for many, many years. I think I'm keen to remove digital clinical safety away from patient safety. That no longer exists. Back in the day when we had a bit of tech, it did. It doesn't now. Anything is linked to patient safety. It's just a system that we use in a form of documentation, and we can be much more efficient with that. We are consumed with documentation burden with the clinical safety process, and I know that's being looked at the centre, which is really welcoming, but we need to be much more efficient. What do our CSOs do? How do they work? Are they doing the same thing over and over again without any communication in their region or their community? So we've got to look at efficiencies for that process, because that's our governance. That's the bit that we need to keep us strong and safe, to make sure that we are professionally accountable and comfortable with the tools that we are using.
Super helpful. Thank you, Jackie. And Mitch, you've got your hand up.
Yeah, I just wanted to build nicely on Jackie's point that, yes, I absolutely agree with the time saving that summarization and large language model reading and so forth and scripting is really powerful. But another powerful way to think about that component is that not only do you want it to tell you what it's summarized, but what you want it to do is to say, what is the confidence level about the component it's summarized? Because if it's only one off that I found an allergy to penicillin in a single record, but actually 2,000 other records where you should have had the penicillin allergy has been removed, then it should say that's a dubious penicillin allergy that I've only found 1 in 2,000 times that I expected to see it, not just actually saw it. And actually there, what I want the AI to highlight is not only, yes, they had an angioplasty and stenting and coronary artery bypass grafting, 3 vessels, etc., but actually we don't know when the left bundle branch block on the ECG occurred, and it occurred with or without pain. I want the uncertainties to be highlighted where we need to clarify the uncertainties. I don't want it to just stick to the middle stuff, which is, hey, I've absolutely got this certain, but actually, didn't you get transient diabetes when you were pregnant with your second pregnancy? And how bad was it? And was it really the early onset of type 2 diabetes will come in the future? You know, I want that subtlety coming through, not just narrow to the focus of that which is common. And so that's the bit that I don't know how to help it contextualize properly, but I need it to understand that it's got uncertainty points, and those uncertainty points are really the art of medicine. A really good historian, you know, gets those subtle little signals and says, well, actually, you've just been abroad, you've swam in a lake, and that's why you've got complete heart block now, because you've swam with rat urine and you've accidentally got an atypical pneumonia that's affected your heart. You know, it won't do that very easily unless we teach it to do that. So I don't know if that helps Jackie to build on that aspect, but yes, definitely save time, but not to lose focus on that little nuances that is the experience of medicine.
Thank you. So just picking up on some of the tangents of the conversations, we've talked a lot about people, we've talked about workforce, a lot of the chat is asking the same questions. Alec, I know we don't have the digital workforce plan with us just yet, we're still working on the 10-year plan, but that is imminent. So I know you can't give away all of the detail at this stage, but just I'd like to ask you a bit of a question there in terms of what some of the views and plan is from NHS England about how we enable the workforce across healthcare to potentially get the benefits out of AI.
Well, I go further, Carl, and say from the benefits from digital data and technology, it's not just AI, because we've not, for reasons I said earlier, we've not even done that, and that leads to poor data quality. So if you don't have highly functional, usable solutions in front of the healthcare professional, they don't get used, and the data that derives from them is not great. So I think there's a recognition that the workforce is not my esteemed colleagues on this call and on this in this virtual room listening, and those others, you know, a few thousand who are in the sort of DDAT workforce. it's got to be everybody. So we've got to make this everybody's business, because actually all of us potentially are members of the public who might need to avail ourselves of the health and care system in the future as well. So I think we are needing to look at, this is about everyone's business, and we've got to absolutely specifically make sure that we are inclusive in making sure the workforce are equipped with those skills. We know, leaving aside the core infrastructure skills of turning on a laptop and stuff, people don't know often how to do and navigate the basics, even using Microsoft Teams. And we've invested in, licenses for 1.8 million staff across the health and care system with Microsoft Teams, and yet we are using a fraction of the capability within it because nobody's been trained to use any of the other 30 applications within the product suites. And we talk about looping in with people. Well, that's Microsoft Loop, but none of us use it. And we know that only 500,000 people of that 1.8 million use Microsoft Teams on a daily basis. So there's a challenge there. So I think we've got to look at this in totality. It's going to be a tall order, but we've got to do it because it comes back to what Jackie said. This should be creating time to care, restoring the humanity and the human focus to what we went into healthcare for in the first place. And that's going to be absolutely critical. These are all tools, and those tools we need to be equipped to use those tools, but know where we're using them in that patient journey and for what purpose. So that I come back to the modern services framework, getting an operational model. We've tagged tech on to a lot of what we've been doing on paper historically, but embedding this now and integrating it properly into a new operating and business model, I think is going to be key, alongside bringing the workforce, making sure we get the communications and the narrative right. And that's why I'm absolutely clear we've got to do this together. I think colleagues on this call know that I'm trying to set a stall whereby we may be creating, policy and standards and strategy at the centre, but we've got to coordinate that assurance layer with our regional and system colleagues, particularly given the challenges everyone is experiencing around digital leadership right now, if we're going to get delivery at place, at provider, in neighbourhood, etc. So this has got to be a collective, it's got to be a collaborative approach, and there's lots to do.
Alec, and this is the first webinar where we actually haven't had a representative from our supplier community giving some of their thoughts and perspectives. So I'm just going to add one thing from them. So it's often easy to say that things fail, technology fails because of the supplier, because of the software, because of the product. It's often much more complex than that. Normally it's a bad buyer, a bad client, a bad delivery, over expectation. They think they've got that extra widget that will make it sing, but it hasn't quite been developed in R&D when it's ready to go. So again, that wider collaboration there, and being crystal clear as a large purchasing organization what it is that you want to buy from that supplier and what it's there, and also making sure that we're not getting snake oil provided to us is going to be a key piece of work there. I would like to come around for a kind of final synopsis in a moment, for because I'm conscious of time. I'm just going to push you one final question, Alec. Is there any update on when the digital workforce plan might be out?
No, but as soon as I know, I'll let you know.
Thank you, Alec. And just a wider couple of questions there in terms of the procurement, which I'd like to come back to you on quickly, Lee, and then I'll come to you, Yvette, for kind of rounding comments. So a lot of people are saying that, we need to understand what it is. You're talking about what the benefits, what you're trying to fix in terms of that business model. It is change. Is there a revenue capital issue here? Is it going to get beaten by something else? So actually my elective care patient list is far bigger and I need you to concentrate on that, Lee, rather than this new fancy whistly thing over here. How do you manage those conflicts internally with this?
So I'd say you manage the conflicts within the organisation by understanding the organisation and working with the partners in there. There's a reality of you need to work on 3 horizons. What's the short, medium, and long term? Some of this we're talking about is medium to long term, but it's also education and understanding. The point of, it's easy to say we won't use some of these new tools because people aren't aware of what they can and can't do, what the risks are and aren't. And it's also the confidence level you potentially get in an organisation. If you look at an organisational level of what's their experience on digital, what's their experience of delivery, and if that's been a poor one today, the chances of getting it through can be quite minimal, especially if the ask is a poor one. And I know there's been some chat in there because I've thrown something in, but Yeah, you can't just ask for £500,000 for Copilot and expect somebody to pay for it. The value of putting Copilot in is massive, but it's how you explain the value and how you explain the productivity improvement, and that improves quality. So you're speaking the language of the people you're working with, not digital babble stuff like we can end up doing. So be part of the organisation, join that tribe as much as your own digital tribe. That's what I would say, Cal.
Perfect. Thank you, Lee. Amit and then Jackie.
I think one part I'd like to highlight from the floor as well in the front line is that our waiting lists and waiting times for everything, of course, they're being managed, of course, they're being looked at, but they're growing and growing and growing. And we're finding these, sort of quasi solutions. Oh, actually, well, you're not waiting. We're actually triaging you. And so the triages happen, but we're not actually managing the patient. We're actually putting them on another waiting list. And then we're triaging you for more tests. And then we're triaging you for those tests to be reviewed. Yes, but when am I going to actually meet the clinician that actually changes my life and actually fixes the problem that I need fixing, rather than just telling me what's happening? And actually, we could be using AI to track the delays that we're causing by system changes. That will be so important for me. The delays to therapy, the delays to adoption of either a drug or a device or a predictive analytics or even a predictive therapeutics or an AI that is actually doing its job really well. The delays to that adoption should be measured in lives and harm done. And that will then drive us to go, really, by not taking these skin analytics for a program or this or that, or a mental health program to help support mild depression, by not adopting that, what are we actually causing as harm that is downstream NHS resource being utilized and taxes going up? So, that would be a really nice place to use AI to say the mess that we're causing, or the kicking the can down the road. Can we measure the harm of that as an economist? Thanks.
Makes a lot of sense to me, and I think it's something which us all working together and sharing means that we start to build this evidence base, because it is missing at the moment. Jackie, if I can come to you.
100% agree with me around that. AI can help all of that. And in terms of workforce, for anybody who has managed staff and rosters and attendance management and long-term sick will know the pain of it and how the system doesn't work with you or for you at all. And that what that gives, the result of that is an inefficient service, an inefficient workforce with gaps that you don't fill and you can't fill because actually your system doesn't support you to do that. AI could help with all of that to make sure that we've got effective rosters, that we can fill gaps in rosters and surgical slots, all of that. We just don't do that well. I mean, I'm going to say I think nurses do it quite well. We manage our time by the hour. Our leave is all completely managed, and that's how we run our rosters. Certainly not as well as we could be, but I think there's a lot that other disciplines could learn from that, and AI could support all of that. I think we're not good. We know that our average national average for sickness is really high, and that's because it's really hard to manage. So remembering all of the dates and the episodes and where you're up to in the policy, and making sure that your long-term sick list, you're using those people effectively. They may well not be able to come and work on your unit as a clinician, but you may well be able to use them in a different capacity, and I just don't think we are efficient in that. AI could support all of that, and I think that's a really good place to start our workforce, our biggest asset.
Thank you, Jackie. That's super helpful as well. Alec, I've just got a small question I'm going to ask for the roundup. Has NHS England got its greatest hits of where you think you could look at doing things nationally rather than each individual trust, community care provider go individually and make their decisions on areas? I'm not saying it's a centre prescriptive decision, but in terms of that kind of wider central guidance alongside funding, which has also been missing from the 10-year plan so far.
No, so I mean, what you're describing is, do we have a sort of blueprint for an enterprise architecture where you can see digital data, technology, and AI being embedded? The answer is no, not right now, but work in progress that needs to be completed pretty rapidly. I come back to that's really the key point. I'm hoping, and I'll be involving colleagues on this call to have a series of workshops in November around the modern services framework, because I think this is the opportunity. The NHS is really going to be predicated and built around a new operational business model that sits on those modern services frameworks. I think the opportunity is that 95% of the digital data technology, wearables, AI, etc., that we need to utilize will be applicable to all of those different modern services frameworks. So the opportunity is there to describe that operating model built on a really modern, resilient digital and data architecture that really then summarizes. And I think we need to be absolutely clear. Things like single patient record. We've got a national program being sort of set up around ambient voice technologies, just really to try and standardize and get a replicable model. But there'll need to be, just in the same way we, and I've generalized already today, the workforce, not being equipped with the skills. We need to understand the different levels and awareness of where AI and digital and data technology skills are required, because it will differ for different parts of our workforce. So I think, again, we need to recognize that delivery takes place at place. There'll need to be that devolution processes around ensuring that you can really start to leverage capability, capacity, but also really innovate at a local level where there's a real requirement. I was on a call yesterday with some amazing work being done in Manchester, Jackie, with GeoPlace and other stuff around citizens' advice using Copilot type devices. There's incredible stuff, and I think that's where we need to be leveraging and looking at that bigger bit. Healthcare is a small component of somebody's lived health or not health experience, and we need to be addressing and working with those other government agencies to build up a picture, but look at how we do that with local authorities within those constituents and those neighborhoods, but do what we need to do where it's right to do it from the center. So we'll absolutely be clear on that, but there's going to be lots of leverage. I think if we can create that sort of almost a playbook model blueprint, then people can start to leverage that, because everyone's at different places at the moment, and I think we need to just recognize that.
Thank you, Alec. So we're going to move into just final roundup. Anything that you feel that we've missed that you want to share, but also just any kind of reflective thoughts, and just a couple of comments at the end of it. If I could come to you first, please.
Yeah, I think if I was to leave it with just one comment, it would be that if we get the people side right and we modernize the DCB 0129, DCB 0160 to fit that adaptive AI, the rest will follow. So everything else, procurement, pilots, productivity, depends on that really solid foundation. And so for me, the takeaway is really simple. So enabling the workforce and updating the guardrails, and the NHS will be ready for safe, confident AI use.
Thank you, Yvette. Lee, if I could come to you.
Yeah, I think, to be honest, AI is a brilliant opportunity. We've just got to be real and manage expectations. But let's not lose the opportunity. That would be my view.
Thank you, Lee. Amit?
Thank you. I think one of the things that has also been slightly missed out, and maybe it's in another forum, is the ability for individuals inside the NHS to have great ideas that could then be surfaced into AI using properly. Because at the moment we're looking at huge corporations making very massive top-down changes on us, rather than us being able to make very quick wins from the floor upwards, and that being tested, trialed, and going outside the NHS to other economies and other places. And I think, for me, the research methodology of, hey, have you got a disease and a drug, or have you got a diagnostic test, or have you got a new solution that you want to test out? We need to make that simpler. And I can't quite see that small person's or small SME's ability to impact and influence and actually spread upwards from the floor. I can only see these large top-down approaches, or these very megalithic, Heidi Health and other technologies trying to hit from multi-different doorways, etc. And I don't. We're missing a trick. It needs to be incubated from the front line and the floor, and then spread upwards, or it's solving an absolute frontline problem very rapidly. Thanks.
Thanks, Amit. I'll come to you in a second, Jackie. I think I just wanted to add to that there is wider scale. There is top down, there is also allowing teams to have pockets of innovation and allowing them to fail fast, fail quickly. You know, the methodologies within F1, within the government digital service, you know, they're well trod, they're written down, and you've got to take away that STEMI of fear and allow people not to spend too much money, but to get on with it and trial and learn. And it also creates that clinical engagement, that workforce engagement by allowing those kind of small teams. I'm trying to avoid the word tiger teams as that's KPMG, but you get the general idea of what I'm talking about. Jackie, if I come to your reflection, please.
Just a couple of points to make. I work in an innovation agency, so innovation is key, failing fast. We work really hard, the 15 HINs, to make sure that we are giving startups a voice. There's an innovation accelerator, and we absolutely promote that. I think that, you know, it's really good to see that the HINs are at the forefront of the 10-year plan, as they should be. This is the open door and the key to a sustainable NHS. Working with our innovation, whether that be a startup or big scale innovation, and our industry partners is a key to sustaining us. We cannot survive without them. We have to change our mindset to innovation and industry partner working. But my two messages on this call for this AI and productivity is demand training, demand it, ask for it, shout from the rooftops, and then reap the rewards, because you will absolutely do that. And then measure your benefits and come back to us, because we'd love to hear about it.
Jackie, Alec?
Echoing all of that, I think, look, we've got a once in a generation opportunity. We're in a different world now, a challenging world, a fiscally challenged world, but we've got an opportunity to create a really socialized, personalized, digitally enabled, data-driven, AI augmented learning, health and care system where the best of science and technology enhances people's lives. But to do that, we need to create the right environment and ecosystem and culture of both connection, collaboration and compassion, and do it together. And I'm really excited about that journey we're going on.
Thank you. I mentioned the digital workforce plan earlier. The only comment I would make as chair's privilege is, please don't let all those digitally skilled, experienced people disappear from the market who are potentially worried about their roles. If we're going to manage our data properly, if we're going to ask the right questions, if we're going to train all of our colleagues, our staff, our patients, those are the people we need there. So hang on to them, please. I'd like to thank everyone from our audience and from Digital Health for giving up their time today. You can see we've got some very senior, very important people here who have day jobs to do apart from talking and sharing on these kind of things. But we find these really valuable for the audience. And again, they always ask new questions. We will be following up with the next webinar series on the single patient record. We'll also be having a deep dive focus into neighbourhoods. We'll be looking at prevention moving forward. And although it's not specifically mentioned in the 10-year plan, we will be also having a session around cybersecurity, as I think it's fundamental to this to make sure that we've got that right as part of it. So do stay tuned. Thank you very much again for everybody for joining. Really appreciate it. Enjoy your weekends once you get there. Take care, everyone. Bye-bye.
Thanks, Carl. Thanks, everyone. You too. Bye-bye.
Bye.
Thanks, guys.